Hi friends, good morning. Welcome to my channel Dr.Sreenivas Medical Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh. Today I am going to talk about a very interesting topic, intracranial tension. And I believe this is going to be useful for residents of internal medicine, neurology, neurosurgery, anesthesia and related specialties. Very interesting topic, and I'm going to touch upon only concepts, and I believe it's going to be really fascinating. So intracranial tension. The normal intracranial pressure is less than 10 to 50 millimeters of mercury. The normal intracranial pressure is less than 10 to 50 millimeters of mercury. To understand intracranial pressure and intracranial tension, we need to understand a very important concept, the Monro-Kellie doctrine. Monro-Kellie doctrine. What does this say? According to the Monro-Kellie doctrine, the pressure of the brain, the intracranial pressure, is basically because of three components. One, the brain; second, the blood; and third, the CSF. So, the intracranial pressure is because of three components. One, the brain; two, the blood; three, the CSF. These three determine the intracranial pressure, and one will increase or decrease at the expense of the other two components. Why the intracranial pressure is dependent only on these three structures is that above the brain it is the rigid skull. So it cannot expand further. The rigid skull will not allow the brain to expand further. And therefore the intracranial pressure depends upon the components which are present in the intracranial compartment, that is the brain, blood and CSF. So pressure really increases in the brain because it cannot expand further because of the rigid skull, which will not allow the brain to expand. So one of the principles of treatment of intracranial pressure, how they relieve intracranial pressure, is to take the CSF fluid from the brain and put it into the peritoneum. Why into the peritoneum? There is no rigid bone or anything over the abdomen which will not allow it to expand. So why I brought this example is that to emphasize that the brain is encircled by the skull, which is rigid, which will not allow it to expand. And therefore the intracranial pressure is dependent upon three components: the brain, the blood and CSF. Now let's see what happens and how useful is this Monro-Kellie doctrine. We need to understand, here is the graph wherein there is an intracranial pressure on the y-axis and the intracranial volume on the x-axis. So the components normally present are the brain, blood and CSF. Now imagine there is a mass in the brain. So what happens when there is a mass in the brain? So the volume of the brain increases at the expense of the CSF and the blood. But the pressure will rise a little. This is known as compensated phase. The pressure will not rise dramatically. Initially it is only a little rise of CSF, rise of pressure, which you call it as a compensatory phase. Why there is a compensatory phase? Because when the pressure increases in the brain, the intracranial pressure increases, the CSF can be left out from the intracranial compartment to the spinal column. So from the intracranial compartment, the CSF will egress from the intracranial compartment to the spinal column, to some extent compensating for the increased intracranial pressure. One. The second point is that the dura can stretch a bit between the falx cerebri, between the cerebral hemispheres and between the cerebellum and the brain, the tentorium cerebellum, the dura can stretch a bit. So initially when the intracranial pressure, when the intracranial volume increases, the pressure is only slightly increased. This is known as compensatory phase. But then about 25 millimeters of mercury, the rise, the curve is very, very steep. It goes like this. It ascends very steeply because the compensatory phase is gone. So any small increase in the brain, in the volume of the brain, will make the intracranial pressure to rise exponentially. So more than 25 millimeters of mercury the curve rises exponentially. So anything in the brain like mass, like tumor or abscess can raise the intracranial pressure, and we have to be very careful because it has got a disastrous consequences. What are the disastrous consequences? One, there is a direct consequence of raised intracranial pressure, what we call it as herniation. When the intracranial pressure rises, the rigid skull will not allow the brain to increase, expand further. Therefore, a compartment of the brain which it goes into the another compartment of the brain which it normally does not occupy. So this is herniation. So the pressure of the brain increases, it tries to come out, tries to expand somehow, and it results in herniation. So what are the types of herniation? We have uncal herniation, where it can go and impinge on the third nerve of the midbrain and cause pupillary dilatation. Uncal herniation. We have central herniation. We have transphalangeal herniation. We have foraminal herniation, where it can impinge on the medulla oblongata and can cause respiratory problems. So when the intracranial pressure increases, there are mainly two disastrous consequences. One is the direct consequence causing herniation. Second is the indirect consequences, where the cerebral perfusion pressure is decreased, resulting in hypoxic encephalopathy. So we are all worried about the raised intracranial pressure because of two consequences. One, a direct consequence causing herniation of the brain. Second, an intracranial pressure will increase, intracranial pressure will decrease the cerebral perfusion pressure. So having understood this Monro-Kellie doctrine, we need to understand another important formula wherein the cerebral perfusion pressure, intracranial pressure and mean arterial pressure are interrelated. So the cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure, and therefore when the intracranial pressure starts increasing, the cerebral perfusion pressure starts decreasing, and person will have hypoxemic encephalopathy and the consequences of hypoxemic encephalopathy. And therefore we should not allow the intracranial pressure to raise, because it will result in herniation. Second, it will result in hypoxic encephalopathy because of decrease in cerebral perfusion pressure. In fact, the goal of the management of raised intracranial pressure is to maintain the intracranial pressure less than 20 millimeters of mercury and maintain the cerebral perfusion pressure more than 60 millimeters of mercury. So two important concepts of intracranial pressure which one needs to understand is, one, the Monro-Kellie doctrine, wherein the intracranial pressure is dependent on the three components: brain, blood, CSF, because the rigid skull overlying the brain will not allow the brain to expand. One. The second important concept we need to understand is that the cerebral perfusion pressure, the driving force of the blood to the brain, is dependent on two factors: the mean arterial pressure and the intracranial pressure. Cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. If you have understood these two important concepts, understanding intracranial pressure and intracranial tension is easy. So one, we are worried, one, after the compensatory phase, there is a decompensatory phase where there is a direct consequence of herniation and indirect consequence of reduced cerebral perfusion pressure. So what are the causes of raised intracranial pressure? All the causes of raised intracranial pressure can be put into four categories. One, the mass lesions like brain tumor or hemorrhage, especially in developed countries. In developing countries, tuberculosis. When there is a mass lesion, it raises the ICP. So when there is a mass lesion in the brain, there is a mass lesion in the brain, it increases the volume of the brain, and therefore the CSF and blood volume will come down, and beyond a certain level it cannot compensate and there will be a decompensatory phase. So mass lesions, especially tumors and hemorrhage in developed countries, and in developing country like India, it is tuberculosis. Second, a brain edema, a brain injury can cause brain edema, which is known as cerebral edema, and can raise the intracranial pressure. So brain injury can cause cerebral edema and can raise the intracranial pressure. Now, I'll spend a bit of time on the cerebral edema. Cerebral edema, basically there are three types. One, vasogenic edema. Second, cytotoxic edema. Third, interstitial edema. So, brain edema of three types: vasogenic edema, cytotoxic edema, and interstitial edema. The vasogenic edema is because of the compromise of the blood-brain barrier. What is this blood-brain barrier? The blood-brain barrier is nothing but the barrier between the blood on one side and the glial cells on the opposite side. Normally, the endothelial cells of the blood vessels are intact. They are tight junctions. They do not allow anything in the blood, in the vessel, to go from the intravascular space to the extravascular space, that is the glial cells. This is known as blood-brain barrier. It is very, very important. Because of that barrier only, whatever chemicals or toxic substances are there in the blood usually cannot enter easily into the brain because of the blood-brain barrier. But when the blood-brain barrier is broken down, like neurocysticercosis or tuberculoma or any tumor, anything in the vascular compartment will enter into the brain. So, breakdown of the blood-brain barrier. So, when there is a breakdown of the blood-brain barrier, it produces the vasogenic edema. So, basically it is because of the tumors and infections like neurocysticercosis or tuberculoma. The vasogenic edema somehow has got a proclivity to involve the white matter. Perhaps the white matter does not offer much resistance to the accumulation of the edema. So usually you see edema in the white matter. So this is vasogenic edema. The second type of edema is known as cytotoxic edema. The cytotoxic edema is because of the decreased oxygen supply to the brain, the hypoxemia. When there is hypoxemia, the ATP gets affected and there is glial swelling per se. So you have glial swelling per se because of the ATP disruption because of hypoxemia. You call that as cytotoxic edema. Right. So vasogenic edema, cytotoxic edema, and third is the interstitial edema. So the main causes of raised ICP are: one, the mass lesions like tumor or hemorrhage. Second thing is the cerebral edema. The other two important causes are obstructive hydrocephalus, and fourth, the obstruction to cerebral venous sinuses like cortical vein thrombosis. So almost any cause of the raised ICP, intracranial pressure, can be put into one of these four causes. One, mass lesions. Second, injury to the brain in the form of cerebral edema. Third, obstructive hydrocephalus. Fourth, disturbances or obstruction of the venous sinuses like cortical vein thrombosis. Right. Now, having understood the causes of raised intracranial pressure, the Monro-Kellie hypothesis, which says the pressure is dependent upon the brain, blood and CSF, and having understood the formula, that is the cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. Now let's go to the clinical features of the raised intracranial pressure. Intracranial tension. Obviously you will have a headache, vomiting and papilledema. In headache, I want to give a very important concept. The pain in the cranial region, the headache, is usually because of the meningeal irritation, meninges, and the vessels in the meninges. The brain parenchyma per se does not produce pain. You cut the brain, there is no pain. So intraparenchymal or any brain pathology does not produce pain. It is only the meninges and vessels in the meninges which causes pain, headache. That's why you get headache in meningitis, because there's an inflammation of meninges. As I said, meninges is a pain sensitive structure, so it causes headache. Second thing is subarachnoid hemorrhage. When there is hemorrhage in the meninges, again the meninges is getting irritated, and since the involvement of meninges is there and meninges is a pain sensitive region, it causes headache. And therefore usually any intraparenchymal hemorrhage usually not produce headache, but subarachnoid hemorrhage will produce headache. So important causes wherein meninges are inflamed or irritated and which is which causes pain because it's a pain sensitive structure are meningitis, second is subarachnoid hemorrhage. And then you have the clinical features of raised ACT. You have the sixth nerve involvement. Why the sixth nerve is involved usually? Because it is a long slender nerve, and second thing, it can get compressed in the petrous part of the temporal ridge. Because of these two reasons, usually sixth nerve is involved. But there could be false localizing signs also. What is a false localizing sign? A pathology is remote from the expected site. A pathology is somewhere, but the expected clinical feature is on another side. These are known as the false localizing signs. One reason is the sixth cranial nerve could be a false localizing sign because of rostrocaudal extension also. You can have third nerve lesions, third nerve palsies also, especially in uncal hernia. When there is uncal hernia, it goes and impinges on the midbrain. The third nerve, the parasympathetic fibers run superficially on the third nerve. So when it goes and impinges on the parasympathetic fibers, parasympathetic causes constriction of the pupil. So that side the pupil will be dilated, the other side pupil will be normal. Anisocoria, asymmetry of the pupil. So a third nerve involvement is also a common feature of raised intracranial tension. Then you can have miscellaneous signs like seizures because of focal involvement, or patient can have cognitive involvement or generalized features of cognitive disturbance because of hypoxemic encephalopathy, a diffuse nature, or as I said, a focal deficit, a local tumor or local abscess can present signs related to the structures it is impinging upon. So how do you monitor? How do you know whether the person is deteriorating, progressing or improving? Obviously you can measure the pressure directly, and second thing, you can monitor clinically by looking at the Glasgow Coma scales, the pupillary size, as I said, the asymmetry of the pupil and the focal neurological deficits. Fine. Now, having understood the intracranial pressure concepts, we would now move on to the next topic, how to manage a case of raised intracranial tension. How do we manage a person suffering from a raised intracranial tension? The goal of therapy, as I said initially, is to maintain the intracranial pressure less than 20 millimeters of mercury and to maintain the cerebral perfusion pressure more than 60 millimeters of mercury. The simplest and the easiest way of decreasing the intracranial pressure is to make the person's head from the supine position to a reclining position of 30 degrees in the midline position, because once the person raises the head, because of the gravity, the CSF flows down and the pressure can be decreased. As I said, in the compensatory phase of raised intracranial pressure, one, there is stretching of the dura, second, there is an egress of CSF from the intracranial compartment to the spinal column. So you're exploiting this physiological mechanism. If you raise the head end of the person from the supine to a 30 degree, the CSF egresses from the intracranial compartment to the spinal compartment because of the gravity. So the simplest and easiest way to reduce at the bedside to reduce intracranial pressure is head elevation, midline head elevation to 30 degrees. Second thing, as I said, the intracranial pressure depends upon the brain, blood and CSF. So obviously you can take the CSF out to decrease the pressure on the brain. So how you can take the CSF pressure out? You can do ventriculostomy, or as I said earlier, you can do VP shunt, ventriculoperitoneal shunt. What is this ventriculoperitoneal shunt? You take the CSF from the ventricle and put it into the peritoneum. Why you are putting into the peritoneum? Because in the peritoneum or in the abdomen there is no bone. There is no rigid bone which prevents the expansion of the abdomen. Unlike the intracranial compartment where the rigid bone will not allow the brain to expand further, here the abdomen can keep on expanding because there is no rigid overlying bone, so it can expand. So you are taking the CSF and putting it into the peritoneum. So ventriculoperitoneal shunt, as I've been stressing, the intracranial pressure is dependent on three components: reduce the brain, volume, or blood or CSF. So one thing which I use is taking the CSF out and trying to reduce the pressure. I'll talk about the later, reducing the brain volume, where you can do craniectomy. I'll talk about it later. And third is the osmotic therapy. Osmotic therapy is that when we give an osmotic solution, because of osmosis, it pulls the fluid from the brain into the vascular compartment. So osmolar therapy, we basically have mannitol or hypertonic saline. Mannitol we give about 25 to 100 grams every 4th hourly, and hypertonic saline we can give about 30 ml of 23.4% bolus. Right. Then another way of reducing the intracranial pressure is giving glucocorticoids, dexamethasone, 4 milligrams 6th hourly. Generally we give steroids for persons suffering from tumors or abscess. It is not that much useful in other conditions. It is basically useful, the steroids are useful to reduce intracranial pressure in basically two conditions. One, the tumors. Second is the abscess like tuberculoma or neurocystic sarcosis or infective pathology. Another method of reducing the intracranial pressure is hyperventilation, where we maintain PaCO2 between 30 to 35. But this is a short-term measure, because initially when you try to do hyperventilation and decrease the PaCO2, there is vasoconstriction and decreased blood flow to the brain. Again, I've been insisting the intracranial pressure depends on three components: brain, blood, CSF. So brain, you can do craniectomy and remove a part of the brain. CSF, you can take it out and put it in the peritoneum or do ventriculostomy. Blood, so decrease blood flow to the brain by causing vasoconstriction. How we can produce this? By hyperventilation and maintaining the PaCO2 between 30 to 35. But if you do an excessive hyperventilation and the PaCO2 goes down, there is severe vasoconstriction and there can be hypoxemic encephalopathy. So hyperventilation is a rescue method. It's a short-term method and it is not a permanent method, because it can do more harm than good. Then, as I said, the formula cerebral perfusion pressure is dependent on the mean arterial pressure and intracranial pressure. So far I've been telling about the ways to reduce intracranial pressure, but there's a way to decrease to increase the cerebral perfusion pressure by not only the decreasing intracranial pressure but by increasing the mean arterial pressure. How do you do that? By giving pressure therapy, dopamine. When you give pressure therapy like dopamine, you are increasing the mean arterial pressure, and therefore the mean arterial pressure starts increasing, the cerebral perfusion pressure also starts increasing, because cerebral perfusion pressure is dependent on an increased mean arterial pressure and a decreased intracranial pressure. This is a driving force of the blood to the brain. And then you can give sedation, because the person is restless, you can give sedation. Suppose the person is refractory to all measures, as I said, you can do craniectomy, take the flap, take the bone out, allow the brain to expand. Craniectomy. Second, you can give hypothermia, maintain a temperature which is less. Hypothermia, because hypothermia is one of the most important neuroprotectants of the brain. Hypothermia, one of the important neuroprotections of the brain. So what is neuroprotection? It helps the brain to tolerate hypoxemic conditions better, and therefore one of the measures of management of intracranial pressure is to maintain a low temperature, hypothermia, and then you can give barbiturate coma. So basically, again I repeat before I conclude my lecture on intracranial pressure. According to Monro-Kellie hypothesis, the intracranial pressure is dependent on three components: brain, blood and CSF. How you can decrease the volume of the brain? By taking the flap out, taking the bone out. Craniectomy, you can allow the brain to expand. So take the flap out of the bone out and allow the brain to expand. Second, by decreasing the blood flow to the brain, like vasoconstriction by giving hyperventilation. CSF, taking the CSF out from the brain and putting into the peritoneal cavity, or a simple bedside measure by head end elevation, where the CSF egresses from the intracranial compartment to the spinal column. So these are the ways of managing intracranial pressure, and I feel this lecture would be useful to residents of medicine, neurology, neurosurgeon and critical care. Thank you for your patient listening. I've enjoyed giving this lecture. I hope you have also enjoyed. The next class we'll meet with another important and interesting topic. Bye. Take care.